Evidence-based nursing care during labor under supervision of Assistant Prof. Dr. Himmat Mustapha, Assistant Professor of Obstetric and Gynecological Nursing, Faculty of Nursing, Banha University. Prepared by أسماء نبوي أبو النصر، أسماء صبحي أحمد. General objective. At the end of this lecture, the postgraduate student will be able to upgrade their knowledge about evidence-based nursing care during labor. Specific objective. At the end of this lecture, the postgraduate student will be able to know nursing management of the first stage of labor, nursing management of the second stage of labor, nursing management of the third stage of labor, nursing management during the fourth stage, how to read and write bartograph. Outline. Management of first stage of labor, management of the second stage of labor, management of the third stage of labor, nursing management during the fourth stage, البارتوغراف. Nursing management during labor. Management of the first stage of labor. 1. History. A maternal health history should include typical biographical data such as the woman's name and age and the name of delivering health care provider. Obstetric history including the estimated date of birth, a history of the current pregnancy, and the result of any laboratory and diagnostic test such as blood type and Rh status, past pregnancy and obstetric history, past health history and family history. History of present labor, labor pain, vaginal bleeding, gush of fluid, fetal movement. List of medication, risk factors such as diabetes, hypertension, use of tobacco, alcohol, or illicit drugs. Reason for admission such as labor, cesarean birth. 2. Examination. General examination, assessment of the woman's body system including hydration status and measurement of height and build. Maternal vital sign. Vital signs are evaluated at least every 4 hours if membrane have been ruptured for many hours before labor onset of, or if there is a borderline temperature elevation. The temperature is checked hourly. Abdominal examination, scar of previous operation, auscultation of the heart and lung sound and evaluate uterine contraction, assessment of fundal level, frontal grip and umbilical grip. Vaginal and pelvic examination. The purpose of performing a vaginal examination is to assess the amount of dilation of the cervix, effacement of the cervix, and position. At some hospitals, periodic pelvic examinations are typically performed at 2 to 3 hour interval to evaluate labor progress. Uterine contraction. The primary power of labor is uterine contraction, which are involuntary. Uterine contraction increases intrauterine pressure, causing tension of the cervix. This tension leads to cervical dilation and signing, which in turn eventually forces the fetus through the birth canal uterine. Activity include contraction, frequency, duration, and intensity. To palpate the fundus for contraction intensity, place the pads of your finger on the fundus and describe how it feels, like the tip of the nose, mild, like the chin, moderate, or like the forehead, strong. Leibold maneuver are a method for determining the presentation, position, and lie of the fetus through the use of four specific steps. This method involves inspection and palpation of the maternal abdomen as a screening assessment for malpresentation. A longitudinal lie palpation, the woman's fundus during a contraction expected, and the presentation can be cephalic, breech, or shoulder. Laboratory studies typically are done to establish a baseline, include complete blood count, blood typing, and Rh factor. Other tests that may be done include syphilis screening, hepatitis B screening, HIV testing. Active procedure: evacuation of bladder. Evacuate bladder every 2-3 hours. Use enema to evacuate rectum that decrease the uterine interior. Help incident and engagement of the head and avoid contamination during delivery. Preparing the vulva: clean it with soap and warm water from above down. Nutrition: food should be prevented during active labor and delivery, but only small amount of clear liquid for fear of menstrual syndrome, pulmonary aspiration of vomitus during general anesthesia. Posture: patient allow walking during the first stage that help engagement, help psychological support, and no IVC compression. Analgesia: in general, pain relief should depend on the needs and desire of the woman. Initiate or encouraging comfort measures such as back rub, cool close to the forehead, frequent position change, ambulation, showers, slow dancing, leaning over a birth ball, side lying, or counter pressure on lower back. Encouraging partner involvement with breathing technique. Ensure that the woman take deep cleansing breaths before and after each contraction to enhance gas exchange and oxygen to the fetus. Respect the woman's sense of privacy by covering her when appropriate. Intrapartum fetal monitor: recommend that during first stage labor, in the absence of any abnormalities, the fetal heart rate should be checked immediately after contraction, at least every 30 minutes, and every 15 minutes during the second stage. If continuous electronic monitor is used for women with pregnancy at risk, fetal heart auscultations is performed at least every 15 minutes during the first stage labor and every 5 minutes during the second stage. Management of the second stage of labor. Diagnosis: the onset of the second stage. The patient feels the desire to defecate. The contraction become more prolonged and painful. Reflex desire to bear down during the contraction. Rupture of membrane, although this is not specific as it may occur early, even before start of labor. Pre-labor rupture of membrane, or later, even to the degree that the fetus is delivered in an intact. Full dilation of the cervix 10 cm in between uterine contraction is the most sure sign. Delivery room: The patient is transferred on a wheel or trolley to the delivery room, put here in the lithotomy position. The lower abdomen, upper part of the thigh, vulva and perineum are swept with antiseptic lotion. Sterile legs and towels are applied. Bearing down. Ask the patient to bear down during the contraction and relax in between. IV oxytocin drip in glucose solution 500 may be given. Delivery of the head. The main aim during delivery of the head is to prevent perineal laceration through the following instruction. Support of the perineum. When the labia start to separate by the head, a sterile pad is placed over the perineum and press on it with the right hand during uterine contraction. This is continued until crowning occurs to maintain the flexion of the head. Posture. Patients allow walking during the first stage that help engagement, help psychological support, and no IVC compression. Analgesia. In general, pain relief should depend on the needs and desire of the woman. Initiate or encouraging comfort measures such as back rub, coil close to the forehead, frequent position change, ambulation, showers, slow dancing, leaning over a birth ball, side lying, or counter pressure on lower back. Encouraging partner involvement with breathing technique. Maneuver upward pressure on the perineum by the right hand and downward pressure on the occiput by the left hand to control the extension of the head. Evacuation. It is done at crowning when the perineum is stretched to the degree that it is about to tear. Swab and aspirate the mouth and nose once the head is delivered before respiration is initiated and the liquor mechanism or blood is inhaled. Coils of the umbilical cord, if present around the neck, are slipped over the head, but it tie or multiple they are cut between two clamps. Delivery of the shoulder. Gentle downward traction is applied to the head till the anterior shoulder slips under the symphysis pubis. The head is lifted upward to deliver the posterior shoulder first, then downward to deliver the anterior shoulder. Delivery of the remainder of the body. Usually slip without difficulty, otherwise gentle traction is applied to complete delivery. Clamping the cord. The baby is held by its ankle with the head downward at a lower level than its mother for few seconds. This is contraindicated in preterm baby, erythroblastoses, fetal suspicions of intracranial hemorrhage. This may be enhanced by milking the cord toward the baby to add about 100 ml of blood to its circulation. The cord is divided between two clamps to avoid bleeding from a possible second involuntary twin. Management of the third stage of labor. Practice within the third stage of labor may be broadly considered as either physiological or active management. Physiological or expectant management involve waiting for placental separation sign and allowing the placenta to deliver, either or aided by nipple stimulation or gravity. In contrast, active management of third stage labor consists of early cord clamping, controlled cord traction during placental delivery, and immediate administration of prophylactic. The goal of this treat is to limit postpartum hemorrhage. Conservative method: put the ulnar border of the left hand just above the fundus to detect any bleeding inside uterus due to uterine manifested by rise of level of atonic fundus. With sign of placental separation and descend appear, massage the uterus, help it to contract to stop any bleeding. At some hospital, periodic pelvic examinations are typically performed at 2 to 3 hour interval to evaluate labor progress. Uterine contraction. The primary power of labor is uterine contraction, which are involuntary. Uterine contraction increases intrauterine pressure, causing tension of the cervix. This tension leads to cervical dilation and swelling, which in turn eventually forces the fetus. Active method: with the delivery of anterior shoulder, ergometrin is given to help separation of placenta. After delivery of the fetus, the uterus strongly contracts and the placenta separate at once. With contraction of the uterus, the placenta is delivered actively by controlled cord traction. Technique: put the left hand on the suprapubic region and push the uterus upward by the ulnar border of tip of the finger. By the right hand, do gentle traction downward and backward on the cord at the same time. When the placenta appears at the vulva, hold it between the two hands and it is rolled to no miss part of the membrane. Inspect the placenta and membrane after delivery for the part. Inspect the perineum and vulva for laceration. Any laceration should be repaired immediately. Wash these areas with antiseptic solution, dry and put sterile dressing. Observe the patient carefully for 1 to 2 hours after delivery of placenta for any vaginal bleeding and vital sign. Care of newborn. Clearance of respiratory passage. As the head is delivered, suction by mucus catheter connected to electric suction is applied to the nose and mouth. Suction may be also applied while holding the baby upside down. After division of the cord, the baby is placed in the supine position with the head lowered and turned to one side. Here, suction may be also applied to confirm clearance of respiratory passage. If respiration is infrequent, it is helped by suction of the mouth, nose, and pharynx, sleeping of the soles of feet. Ligate umbilical cord by plastic sterile clamp and cut the cord distal to clamp. Paint the stump by alcohol. As the baby temperature drop after delivery, the infant must be cared for in a place with thermal regulation, otherwise chilling occurs. Inspect the baby for congenital anomalies. Take neonatal measure the weight. Membrane intact Apgar scoring evaluation the condition of the baby at 1 and 5 minutes to assess the degree or asphyxia of the newborn. Heart rate 0 absent 1 below under mid-minute 2 over more than mid-minute. Respiration 0 absent 1 slow or regular 2 good cry. Muscle tone 0 absent 1 some affliction 2 active movement. Reflexes 0 no response 1 grimace 2 sneeze cough. Colors 0 blue or pale 1 body pink limbs blue 2 all pink. Scoring system 7 to 10 good condition 4 to 6 moderate asphyxia less than 4 severe asphyxia. Nursing management during the fourth stage. The fourth stage of labor begins after the placenta is expelled and lasts up to 4 hours after birth, during which time recovery takes place. This recovery period may take place in the same room where the woman gave birth, in a separate recovery area, or in her postpartum room. The focus of nursing management during the fourth stage of labor involve frequent close observation for hemorrhage, provision of comfort measure, and promotion of family attachment. Assessment during the fourth stage centered on the woman's vital sign, status of the uterine fundus, and perineal area. Management of the third stage of labor. Practice within the third stage of labor may be broadly considered as either physiological or active management. Physiological or expectant management involve waiting for placental separation sign and allowing the placenta to deliver, either or aided by nipple stimulation or gravity. In contrast, active management of third stage labor consists of early cord clamping, controlled cord traction during placental delivery, and immediate administration of assess the woman's comfort level, lochia amount, and bladder status during the first hour after birth. Vital signs are taken every 15 minutes, then every 30 minutes for the next hour if needed. The vagina and perineal area are quite stretched and edematous following a vaginal birth. Assess the perineum including the episiotomy if present for possible hematoma formation. Assess the woman's comfort level frequently to determine the need for analgesia. Ask the woman to rate her pain on a scale of 1 to 10. It should be less than 3. If it is higher, further evaluation is needed to make sure there aren't any deviations contribute to her discomfort. Assess the vaginal discharge lochia every 15 minutes for the first hour and every 16 minutes for the next hour. Palpation of the woman's bladder after each voiding help to ensure complete emptying. A full bladder will displace the uterus to either side of the midline and potentiate uterine hemorrhage secondary to pregnancy. Applying an ice pack to the perineum to promote comfort and reduce swelling. Assisting with hygiene and perineal care, teaching the woman how to use the perineal bottle after each bath change and voiding help the woman into a new ground. If respiration is infrequent, it is helped by suction of the mouth, nose, and pharynx, sleeping of the soles of feet. Ligate umbilical cord by plastic sterile clamp and cut the cord distal to clamp. Paint the stump by alcohol. As the baby temperature drop after delivery, the infant must be cared for in a place with thermal regulation, otherwise chilling occur. Inspect the baby for congenital anomalies. Take neonatal measure the weight, height. Culture practice after birth. Describe the lochia flow and normal parameters to observe for postpartum hemorrhage. Teaching safety technique to prevent newborn abduction. Demonstrate the use of the portable sits bath as the comfort measure for the perineum if she had a laceration or an episiotomy repair. Assist with ambulation when getting out of bed for the first time. Providing information about the routine on the mother, baby unit or nursery for her stay. Observing for sign of early parent-infant attachment. Fingertip touch to palm touch to unfolding of the infant. Partogram. Concept of partogram, the diagrammatic representation of labor, recording every event in the whole process of labor. Active method. With the delivery of anterior shoulder, ergometrin is given to help separation of placenta. After delivery of the fetus, the uterus strongly contract and the placenta separate at once. With contraction of the uterus, the placenta is delivered actively by controlled cord traction. The focus of nursing management during the fourth stage of labor involve frequent close observation for hemorrhage, provision of comfort measure, and promotion of family attachment. Assessment during the fourth stage centered on the woman's vital sign, status of the uterine fundus, and the perineal area. Active procedure. Evacuation of blood. Fetal heart rate by binaural stethoscope or sonocy. Normal fetal heart rate 120-160. Indicator for fetal distress 160 بيت تاكيكارديا. لو أكبر 160 تاكيكارديا، لو أقل 120 بريديكارديا، أقل من 100 سيفير بريديكارديا. irregular rate. membrane and liquor. intact membrane. rupture membrane زائد clear liquor. rupture membrane زائد meconium stained liquor. rupture membrane زائد blood stained liquor. rupture membrane plus absent liquor. Molding the fetal skull bone. Molding is an important indication of how adequately the pelvis can accommodate the fetal head. Increase in molding with the head high in the pelvis is an sign of equivalent pelvic disposition. Separated bone suture felt easily, bone just touching each other. Overlapping bone. Severe overlapping bone. Fetal heart rate by binaural stethoscope or sonocy. Latent phase. It starts from onset of labor until the cervix reach 3 cm dilation. Once 3 cm dilation is reached, labor enters the active phase. Last 8 hours or less, each contraction lasting 20 second, at least 22 ل 10 minute contraction. Active phase contraction at least من 3 ل 10, each lasting من 40 ثانية. The cervix should dilate at a rate of 1 to 1 to 2 cm hours for primary and 1.5 cm for multi. Acceleration phase up to 5 cm dilation. Maximum acceleration phase from 5 to 9 cm dilation. Deceleration phase 9 to 10 cm dilation. Alert line. The alert line drawn from 3 cm dilation represent the rate of dilation of 1 cm لكل ساعة. Culture practice after birth. Describe the lochia flow and normal parameters to observe for postpartum hemorrhage. Teaching safety technique to prevent newborn abduction. Demonstrate the use of the portable sits both as the comfort measure for the perineum if she had a laceration or an episiotomy repair. Assist with ambulance. Fetal heart rate by Bernard stethoscope or sonocy. Descent of the fetal head. It should be assessed by abdominal examination immediately before doing a vaginal examination using the rule of fifths to assess engagement. The rule of fifths means the palpable fifths of the fetal head are felt by abdominal examination to be above the level of symphysis pubis. When 2-5 or less of fetal head is felt above the level of the symphysis pubis, this means that the head is engaged. Once 3 cm dilation is reached, labor enters the active phase. Uterine contraction. Observation of the contraction are made every hour in the latent phase and every half hour in active phase. Frequency. How often are they felt? Assessed by number of contraction in a 10-minute period. Duration. How long do they last? Measured in seconds from the time the contraction is first felt abdominally to the time the contraction phase of each square represent one contraction. Maternal condition. Assess maternal condition regularly by monitor drug, IV fluid and oxytocin if labor is augmented, pulse, blood pressure, temperature, urine output, urine analysis for protein and acetone.